Mind again.
So you are talking to Dr. O'Hale, who is a ST2 student, and he want to know about the prescribing gentamicin. Okay.
Okay. So I'll start now. Good morning.
Good morning, doctor.
Hi, Dr. Rohil. How are you?
Yeah, I'm fine, doctor. Thank you.
Okay. How are you doing in our unit?
Yeah, I'm fine, doctor. It's very good, and the people are very helpful here. So
That's
it's
great.
going very nice.
Yeah, that's great to hear. As you know me, I'm Dr. Noor. We keep meeting daily in the rounds.
Yes, doctor. I know you.
Yeah, so I just want to ask you, I got to know that you have some concerns and you wanted to discuss about it. So can you let me know what is your, what you want to?
Yes, doctor. Yesterday, a few doctors are discussing about gentamicin, and they are telling some precautions and some levels, trough levels. So I'm not getting that. So why they so much worried about to prescribe the gentamicin and too much? So I just want to know about that.
I appreciate your interest in this, and you have your observations as well about the trough level and all. Let's discuss about it. But before that, I want to ask you, do you want any of your colleagues to attend this session with us?
No, doctor. I think everyone is busy. So you can continue, please.
Okay, as you said, yes, gentamicin is we are so much worried about the levels and all in neonates, especially because the gentamicin has some side effects. Do you know what are the side effects of gentamicin?
Yeah, doctor, I know this one may affect hearing and some renal problems.
Yes, you're very correct. So we call it as, for hearing, we call it as ototoxicity. For affecting renal, we call it as nephrotoxicity. These two toxic effects of gentamicin make us very cautious about it, especially in the newborns or neonates, because maybe
Okay.
if we don't give the right dose or if the dose gets increased, they will have hearing loss, which might make them lots of problems in their speech
Yeah,
and
okay, doc. So, doctor, how much dose we are giving for the neonate?
yes, it's a very good question. Actually, for the neonate, we are giving 5 mg per kg dose, but you should always check his age. Is he less than 7 days or more than 7 days? Okay.
Oh,
If,
okay.
if the neonate is less than 7 days, we are giving every 36 hours. If he is more than 7 days, we are giving every 24 hours. Okay. Can you think
Oh,
why we are doing this difference? Any idea you have?
I think in first few days, as kidneys are not working for newborns properly, and they not have good output, so that's why, because this gentamicin mostly accumulate in kidneys if they're not working proper.
Yes, you are very right. You can just say it like this, that they are still maturing kidneys, means the kidneys are still maturing. They are less than 7 days baby kidneys are not as mature as more than 7 days. Okay.
So,
So
doctor, my question is, so how we will check that this level they are discussing this about the
very,
level?
a very good question. So what do we do? First, for any child, before starting gentamicin, we will do some basic tests. The main test is, as we know that it is nephrotoxic, we will send for kidney function tests. Okay.
Okay,
Okay, but
okay,
if the child is septic, we will not wait. We will just start the gentamicin, but we will follow up the kidney function tests. Okay.
uh-huh.
Suppose the kidney function test is normal, then we will send immediately before the second dose, the trough level. Okay. So that before the third dose, we will get to know whether what should we do, what will be our decision, whether we will give the dose or we will delay the dose.
Okay,
Okay.
doctor. But if for example this level is coming more, so there is certain level. Can you tell me there is specific certain level that is normal and
I like your observation. Actually, you're working hard to learn the neonatology. So what it is more, if you will see 2 mg per liter. Okay, this is a trough level. If it is less than 2 mg per liter, you're safe. You can give the dose, whatever is your prescribed time. Suppose the baby is less
okay,
than 7 days, you're giving 36 hours, you will continue it. But
okay,
you get the trough level more than 2 to 3, means more than 2 and less than 3. Okay, between 2 to 3, then you will delay your dose to 12 hours. Okay, this is how the trough levels will help you
if
to
it is more than 3, doctor?
yes, very good question. If it is more than 3, we will again delay for 12 hours, but at the same time, before that, we will send the trough level again before giving the dose.
Okay.
Okay, so tell me if you have any other concerns.
Yeah, doctor, I was thinking that is there any like we are giving this gentamicin, is there any contraindication that we should not give?
Yes, very good. Have you read any contraindications about gentamicin?
Which I was thinking, doctor, if the child is not passing his urine, so we should think of that. We should not give, or at least we should discuss with our consultant. What do you say? Or
Yes.
already he's in he's having problem with his kidneys, so that
Yes.
time we should avoid.
Yeah, very good concern you have actually. See, any sick
6 minute
baby.
finish.
Okay, thank you, doctor. Okay, any sick baby, first of all, I want to inform you that this will be given in the perinatal sick babies, septic babies. Okay, so any sick baby, we will involve the consultant from beginning. Okay, this is one thing.
Okay.
The second thing, yes, if the baby is anuric, we are very cautious about the trough levels. Normally, we will send the trough level before second dose, but in the babies who have problem with the urine, we will not give the second dose unless we get the trough level. Did you understand what I'm telling?
Yes, doctor, I understand.
Yeah, you're more
Okay.
cautious about it. So you were
Okay.
asking me about some contraindications, right?
Yeah, yes.
Yeah, I will tell you to easily to remember. Since this drug is ototoxic, as we discussed, any drug which causes ototoxicity or nephrotoxicity, you should avoid simultaneously giving with the gentamicin. Okay.
Okay.
Okay. And also, if there is any family history of problems caused by gentamicin before, like maybe mother was given gentamicin before and she had some hearing loss due to it, like this, if you know, you should avoid gentamicin. Okay, as such, there are no serious complications with gentamicin other than this ototoxicity and nephrotoxicity. Do you have any other concerns?
No, doctor. I was just thinking that if the child renal function is coming normal and gentamicin levels are normal, so
Mm.
we will have to again check the levels, or we should safely give the medicine.
Yeah, very good question. Actually, we will check every third time, every third dose before giving. We have to check, because these babies are
Okay.
small and we have to do it.
Okay. Thank you, doctor.
So, Dr. Rohel, in a short period of time, I gave you lots of information. So, what I will do now, I will give you some leaflets and trusted websites to read
9 minute finish.
about
Okay.
it. Okay. So
Okay.
today we
Thank
were
you, doctor. Thank
discussing
you.
about gentamicin prescription in neonates. So any doubt, anytime you can approach to me. Okay.
Okay. Thank you. Thank you very much.
Thank you. Okay.
Yes, Dr. Noor, you have done very nicely, and there was no wrong information was not there anything, but like a few things. Just you are talking too much. you want to give too much knowledge, I mean to say.
Mhm.
So that's why
Yeah,
it's
because you know,
not complete.
nowadays they told them not to ask much question to the student.
No,
So,
no, no, no. I'm not saying that two-way traffic, but I'm saying
uh,
uh, just to complete it in 9 minutes. So you can use a smaller phrase, small phrases or
okay,
something like
okay,
this.
okay, okay,
This
okay.
one I'm saying. This one
Okay.
I'm saying. Okay.
Small phrase means give me some examples.
Like when I ask you about the trough level, so at last, the last I asked you again this contraindication.
Mm.
So just you can say that there are few contraindications, like if the child is not passing V, or he's having some renal problems, or if we'll have to think that if we are giving any other medicine which can cause his autotoxicity, like this, simple, in 5 seconds, 10 seconds maximum. So
Mm.
that time you have given me a lot of before going to the contraindication, you start another things which you want, which I have interrupted you, so I was not interesting, but you have given me the information. That's okay, no problem. But just to
Yeah, yeah, I got
conclude
your
in nine
point.
minutes.
Okay,
Yeah,
I got your
just
point.
to conclude in 9 minutes, I mean to say. One
Mm.
more thing, when I asked you about how we are checking the trough level and how we are giving the medicine, uh, how we are giving the medicine. So you just tell me we will check the renal function. First, you will check the output. Okay.
Urine output.
Yeah, urine output is the most important than the renal function,
Mhm.
because for the renal function we cannot wait. The result will come, so we can give the medicine as the child is may have perinatal
Sepsis.
sepsis. But if the child is not passing the urine at all, so that time we will have to discuss with our consultant.
Anuria, you mean?
Yeah. So this is a contraindication actually. So we will have to discuss with our consultant.
Mm. But as I told you, also any serious baby from the beginning, would have
Yeah, yeah,
involved.
that one you told me we should not wait and we should give the medicine. Definitely we will give the medicine, but anuric is a very
Yeah,
this
because
is,
in anuric, second dose you will not give before you get the trough level. But in normal
yes,
baby, you can give the second level and you can wait for the trough level for the third dose.
information was very there was no wrong information.
Yeah,
I
but
don't think
there
so.
will be one more questions like this. They can also ask the same way, like in the preterm and the term. Again, for example, in the term baby, you will be considering to give 24 hourly. In the preterms, maybe more than 7 days also, you will start continuing the same 36 hours. They can ask
Yeah,
that also. So the for
yes,
that, as I told you, that answer, immature kidneys, the same answer we will give. Still the kidneys are
yeah,
maturing and they cannot means the gentamicin will be excreted or removed out from our body through the kidneys, right? So
yes, yes.
the kidneys are immature and they cannot remove it as much as possible. This is the reason you will there is difference in the timing. This is how we can
Okay.
explain. But the thing is, I don't know what about summarizing and all. Now
No,
we
no, there is no issue. There is no issue. If you don't have time to summarize, they will not deduct.
okay. And also this, if I summarize, it's okay, even though there is student.
Yeah, yeah, no problem. If student is not willing, you
Hmm.
can summarize and you will get full marks. No problem.
Okay.
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 So,
But ideally, if
next,
everybody has to summarize, and whenever the ring bell is there, then that this
the
one, the
ideally
3 minutes
should
have left, you should be cautious. And even you can say, okay,
No,
I
no.
will, I have short of time. I
Hmm.
have a short of time, so I can understand your concern, but we can summarize as the discussion we have done.
No, no.
Better we can summarize.
Okay. Actually, even in the exam, if the bell rings also, in the exam, they did not told the candidate like she's telling something, or even the role player is telling something, they did not ask them to stop immediately. They asked them to complete their sentence and stop. Okay, in such a situation you can give summary like in one sentence, like how I gave you. Like today we were discussing about gentamicin prescription in neonates, like this. At least one line, or at least you can tell, and you can end, no problem. They did not ask you to immediately leave the room. That's what I got the feedback from the candidates. What they told, even the time finish, whatever you are speaking, just complete it and stop, like that. Okay, this is what the feedback I got. So don't worry, even if, yeah, you should be cautious. And usually they will all, sometimes, you know, the role players may take you to the last. At that time, leaflets, if you start summarizing long, you will miss leaflets. It is also very important. So say the leaflets and trusted websites fast, and then you can summarize very short summary in 1 or 2 sentences. Okay. Okay, we will go to the next case. If you want to add anything, please add. Dr. Yasser, if you want to add anything about gentamicin prescription.
No, you describe it very nicely, and everything is included. You mentioned.
Okay,
so
some
nothing is
points they can ask you, like what precautions you have to take during giving the gentamicin. What means the nurses and during the prescription, 2 nurses should check it always. Okay, and the nurse who is preparing should wear a separate distinct apron, so that everyone knows that she's preparing gentamicin and no one should disturb her. And always one more question can be asked, like how about the writing, the timing of the dose. Always write in 24-hour clock pattern. Okay, that is important. Like you will write 22 hours, not 10 p.m. You will not write 10 p.m. You will write 22 hours. And this is very important. And 36 hours is usually will cause mistakes. Okay, so the time calculation and mentioning the time in the chart is very important. And a nurse should do the checklist, like what time she gave, and if she received the trough levels, did she inform the doctor or not, and if there was any dose changes, did the doctor changed, and did she followed or not. Every checklist will be done. So ultimately, why you are doing so much of work against gentamicin is this, as we told, to prevent ototoxicity and nephrotoxicity, like this only. It depends upon what question the role player will ask. Okay, and another thing, I think more than 30 seconds I was speaking. This is also there.
This one also.
Yeah, but I was not much interested this time to ask more questions, because I don't know. I got feedback from 2-3 candidates that last time when what happened in what minute.
You have to talk to a medical student, John, regarding the febrile neutropenia.
Medical student or mother?
Medical student.
Okay. Just give me 1-2 minutes.
Okay, no problem. You can take your time. Start now.
Hello, good morning.
Good morning.
How are you, John?
Yeah, I'm fine.
I think you know me. I'm Dr. Adnan.
Yeah, I know you. I think we met in the morning in the round.
Yes. Oh, how is your going rotation here?
Yeah, that's
are you
great.
happy? Are you happy here now?
Yeah, I'm
that's
happy.
great. So, I think you have some concerns about febrile neutropenia. You want to discuss about that?
Yeah, doctor. I want to discuss about febrile neutropenia.
Okay, that's really a good that you have chosen a very good topic. And so before we start, would you like to wait your colleague, or we should start?
No, no, we should start.
Okay. So John, may I know that what is febrile neutropenia? Do you have any idea?
Doctor, in leukemia patient, all those patients who develop fever, I think so, we called it febrile neutropenia.
Yes, you have a very basic good knowledge. So I will tell you the proper definition. If any child who is having leukemia and got this fever more than 38 degrees centigrade and his neutrophil count is less than 500, so we label it as febrile neutropenia. Are you getting my point?
Yeah, yeah, I am getting with you.
Okay, that's great. So why we are too much worried about febrile neutropenia, and every time we are advising for the cancer patient? What do you think?
I don't know. That's the reason I choose this point for you.
Okay, that's great. Also, okay, I will tell you that. So if anybody is having this temperature, so that's maybe due to the unwanted effects what we medicine are giving for killing these cancer cells. We will have to be aware of they may get more serious infection. So that's why we are too much worried and we are giving advice to the parents. So are you with me?
Yeah, I am with you, Dr. Tanan. But would you like
So
to tell me?
yeah, I'm listening.
Yeah, would you like to tell me if somebody has febrile neutropenia, how can we proceed?
Yeah, this is really a good question. So first of all, what we'll have to assess the child. So clinically assessment, like we will have to see he's stable or not stable. This is our the first thing. And if he's stable, then we will have to send blood culture, urine, stool cultures, and other things like CBC and all other things. So we can send that and we can start antibiotic. We will admit the child and we will start the antibiotic.
Okay.
And what do you think if the child is not stable? So that time, what should we do?
Yeah, we have to give him, we have to send the septic workup and we have to start antibiotics as you told me. But doctor, every patient we have to admit in the hospital.
Well, this is a good question. If they have labeled as febrile neutropenia, we will have to admit. And as I told that before you tell me, if the child is not stable, is hemodynamically compromised. So first of all, we will have to check airway, breathing, and circulation, and appropriate resuscitation. We will have to start. May he need IV fluids? May he need? We will start antibiotic definitely, and we will do some test also. But we will have to stabilize him first.
Okay.
Okay.
And
Yeah.
yeah. And what are why we don't allow the parents regarding paracetamol at home?
Yeah. Again, this is really a good question. See, if the patient is having a fever and the parents are giving paracetamol, it will mask the fever. It will hide the fever. So this is our a good indication that the child is getting fever. Maybe he's having some serious infection. So that's why we are advising parents that they shouldn't, if the child is having any time fever more than 38, they should come to the hospital immediately. I think
Okay.
it's sound better to you.
Yeah, yeah, I am understand. But would you like to tell me that can we discharge the patient with febrile
Well,
neutropenia?
well, yeah. There is a criteria. If the child is not having any uh, uh, fever more than 24 hours, and we can stop antibiotic. And if he's not got any in positive bacteria or any virus in his blood after 48 hours, so we can discharge.
Okay,
Okay.
okay. And doctor, what do you advise to the parents of such patients?
Yeah, we will advise again the same, that if any child is, if any time the child is getting fever, they should not give the paracetamol, and the fever is more than 38, they should come to the hospital immediately. This is the thing. And they should do a proper hygienic
6 minutes.
measures. Okay. Hygienic measures at home anytime, like the child is on this immunosuppressant drugs. So there should be some kind of hygienic. And anytime if child is get, uh, I mean to say, if any child in the family or his get contact with the varicella, they should contact immediately, even the child is not having a fever. Okay.
Okay, Dr. Dan, would you like to tell me what the precautionary measure we have to take while managing in emergency?
Yeah, precautionary measure, first of all, while we are admitting it, so we will admit in the isolation. This is the first thing. Definitely, who is attending this child, he will should be measures, all hygienic measures like PPE, what we are doing, and all these things. Or any child, any visitor is coming, again we will say that they should wears this PP and all these hygienic measures. This is the most important thing.
Okay, and regarding uh, what we advise to the patient also.
uh, Patient, like he's should be comprised to the medicines and complies to the medicines, and if any time he's getting fever or contact with any varicella, he should tell to the parents and they should contact. And anything else, maybe I don't know at the moment, so I can check and get back to you. So I think, John, I have given you a lot of information today in a short period of time, so we can have another meeting. And would you like to summarize for me what we have discussed today?
Yeah, we have discussed febrile neutropenia, its definition, its management, and the precautionary measures the parents has to take at home.
Okay, that's great. So I will give you some leaflets. You can go through, and we can have another meeting. And I think I have a suggestion. If you can present this in the morning meeting, that will be a benefit for others also.
Okay, okay. Thank you.
Okay. Okay. Thank you, John. Thank you for a good meeting. Thank you very much. Yes.
Yeah, everything is fine. Just only one thing. If
Okay, 20 seconds left. Okay, you can give the
Okay.
feedback.
yeah, but main question is this one: the things which was asked from you, just give the answer, and the others give the time that he will answer. Don't give the booster of information to him. Just like varicella, I did not ask you, so you don't need to give
No, no,
any.
you ask me the advice. So in the advice, we'll have to give the varicella for also, because the child was an immunosuppressant. Because they
You
not
say
have written in the guidelines, they have not written any guide for the advice in the febrile neutropenia. But if the child is immunosuppressant, so these are the main advices which we are giving. They have written in the guidelines. So that's why I have given, because this answer was not in the guideline.
okay, and the other
Yeah,
thing
that's why. I
we
don't know.
okay, okay,
That's why I said that I will check again.
okay, no problem. Uh,
Yeah, yeah. Tell me, tell me.
the other thing is this one. Always mention the social groups. This one, the parents of
I don't
other.
know this one for febrile neutropenia. Is there any social group? I don't know. That's why I did not mention. There are specific social group like Turner social group, Down social group. This is social group is there or not? I don't know. That's why I did not mention.
Okay, okay.
Maybe leukemia. For leukemia, they can have, not for febrile neutropenia. Maybe
Yeah, for
leukemia they can
leukemia
have.
patient, they have some social group, so they
Yeah,
get some
maybe they have.
information
Yeah,
Yeah,
for
yeah.
leukemia, not for
yeah.
febrile neutropenia. But
You can refer to those social groups, no problem,
Yeah,
because
yeah.
there the problems will be same. Yeah.
Yeah, Dr. Noor, it's your time to give feedback.
Okay, I think it went very well. When you asked previous knowledge, I got my thing. I did not ask previous knowledge actually. I should write actually. This time I did not write. I always write before starting. I should ask for previous knowledge and attendance. This time I did not write. That's why I forgot. When you asked, I remembered. This is my feedback to myself. Okay, your definition was very nice. And also you asked for attender and your explanation about unstable patients was very good. And when he asked about the discharge, also you should tell about their cells should be more than 500 along with the stability.
Yeah.
He asked you about when can we discharge, right? One thing is, as you said, if the fever is reduced and cultures did not show any bug and the child is stable, at the same time, his WBC's level should have raised for you to discharge. If it is less than 0.5, in febrile neutropenia, as I know, the worry is gram-negative sepsis, right?
Yeah.
Yes, yes.
So even if he is stable presently, but his cells are less than 0.5, then maybe taking the decision to discharge will be difficult. So in the discharge criteria, you should, apart from being stable, hemodynamically stable, and the fever has reduced and nothing came in the culture responding to antibiotics, you should also consider the increase in the cells. This is my one point. I think fever, along with advice, we just can't tell about fever and stop. Maybe whatever is there, as you said, varicella, because they are on immunosuppressant drugs, can be considered. Better to go back and see also if anywhere written this one. Then very good precautions, isolation and PPE. This is given very good. Patient, I don't know what was there in Dr. Yasser's mind. Let him tell. About the patient advice, what you wanted to tell Dr. Yasser?
Means just to avoid the others infection persons. Just like
hygienic measures.
yeah.
Yeah, we should teach him hygienic measures and also ask him to be away from anyone he thinks that he has cough, cold, or any sort of infection.
Just like daily bath, hand washing, perianal care. You know, they have perianal ulcerations due to mucositis. They develop neutropenia associated with mucositis. You know, and so mouth care. They are on prophylaxis, some gurgles and some prophylactic antibiotics. So these are the prophylactic measures. They have to continue it because it's very difficult to keep them. They are doing gurgles 4 times a day, and they are using Septron as a prophylaxis. So it's very difficult for everyone to keep 8 times gurgles and to use this Septron, trimethoprim for 2 days of a week, and thus hand hygiene and other care, daily bath, such type of. So it's very difficult. So we have to counsel them regarding the importance of this one. And there is one thing, we are giving this febrile neutropenia card.
Okay.
The patients, everything is written there, and we are providing to them in case. So we can, if it comes with the mother, so just ask them, do you have this febrile neutropenia card with you or not?
Okay.
And
This
second thing is sorry,
uh,
really sorry. Temperature is 38.5, not 38.
I think 38 also is given in the guidelines.
Okay, I will check again. And the other thing, there are 2 approaches. First approach is as you told, if ANC is more than 500, we can discharge them, and clinically stable, we can discharge them on antibiotics. And
on
then
oral antibiotics,
yeah,
in consultation with the oncologist or or your consultant. That is very important.
yeah. And if ANC less than 500, we admit them and we continue them antibiotics till 48 hours, until blood culture came negative and afebrile for last 24 hours, and ANC more than 500.
Okay. If they are continuing fever, also if they are continuing fever more than 48 hours, then
Admit.
yeah, they will be continuing in admission only. But you will also consider more than 96 hours. If there is no response to antibiotics and continuing fever, you will think of fungal infections, right?
No. If 72 hours, if no respond, we added vancomycin to consider staphylococcus. And if 5 days, 5 days, I don't know exact hours.
In the
If-
guidelines, I read 96 hours, more than 96
No,
hours.
no, this is 96 hours, Doctor.
okay.
Yeah, this is in the guideline. They have written 96 hours. If there is already known MRSA, then we can give the vancomycin.
Okay, I will check again because the practically we are using just like this one. I will check it again. Okay, because okay, khalas, no problem. I will check it again. No problem.
Only I will show you, it will not take much time. See here, he has written very clearly.
They have written previous documented MRSA infection, add ecoplanin, okay, or vancomycin if previous, which I have told you.
See here, he has given, if febrile after 96 hours or clinically unstable between 48 to 96 hours, it means continuous fever after 96 hours still, or they are clinically unstable between 48 to 96 hours, means they are not responding to what treatment you are giving, you can initiate investigations for fungal infection. So the investigation you will do is the ultrasound, abdomen, chest x-ray and CT. Just
Yes.
and you will consider this amphotericin B addition. Okay.
Yeah.
This is important if they are not responding. Okay, but they are still febrile after 48 hours, then you will consider repeat blood cultures and involve your consultant and oncology team. And you will also consider changing antibiotic from tazocin to meropenem more than 48 hours. If there is no response to tazocin, you will change to meropenem, but you will chase cultures. This is very important. The word chase cultures means you are in desperately or waiting to get the cultures to manage the patient. Okay, this is very important to identify the bacterial, viral and the urine microscopy. Okay, I think we can go to the next case. So the important questions in this case can come is, what is the febrile neutropenia? We have to explain. And about the paracetamol. So for these patients, we will not prescribe paracetamol at all. The advice will be, any fever, come immediately to hospital, right?
Yes.
Okay. Okay, so in the mother, all these things what we said, the same thing we will tell, but we will use the all, see to it that no jargons and layman terms we will use. Okay. So what is the next case?
I have given you the picture.
Okay, so candidate me or Dr. Yasser. So keep our names in your mind. Okay, keep one as A and one as B. Okay, And
Okay.
let Dr. Yasser choose the A or B. Okay.
Okay.
So keep me or Dr. Yasser as A as per your choice, and B as another one, and let Dr. Yasser choose which letter you want, Dr. Yasser.
B.
Okay, who is
B. So Dr. Yasser will do.
okay? So
See, very fast response, Dr. Yasser, for you. I was thinking B for Yasser. Even Dr. Noor name was not in my mind for A. I was just thinking B for Yasser, and again he said B. Okay, that's good. Okay, Dr. Yasser, this is let's say this is 2 years old, but looking 1.5. Okay, 2 years old child, and you can see in the picture. Please do general physical examination.
Any name?
Name is Jack.
okay, you can start now.
Okay, I will enter the room, wash my hand, introduce myself to the mother of Jack, check the mentality and the speech of the Jack, and take permission from the mother, expose her, and then I will check for surrounding, any wheelchair, any crunches, any hearing aids or any glasses.
Dr. Adnan, you should open your mic. Hello.
Oh, sorry. I am speaking. No, there is nothing.
Okay, then I will also any height and weight and OFC.
Yeah, his upper segment is 38 centimeter and the lower segment is 30 centimeter.
Okay, weight, OFC.
Weight is normal. Okay, and the OFC is also normal.
Okay, how is he? Well looking, ill looking? Any distress? Any dysmorphism?
No distress, no dysmorphism you can see in the picture, but no distress, and he's having what you ask? Yeah, well looking.
Okay, I want to check the gait of the child. Can he walk?
Yeah, this is just 2 years. He cannot walk properly. He's walking like broad base gait, but not cannot walk properly.
Okay,
Broad base,
okay, okay.
straddling.
Then I want to start from the hand. Initially, I inspect as I am looking in the universal cue. He has wrist widening. He is having Harrison sulcus, rachitic rosary, and also having prominent frontal bossing and maxillary prominence. And also he has distal uh, this ankle swelling of both side of the. Okay,
Okay.
I will start from the hand to see any clubbing, any oligonychia, any pallor.
No, just pain,
Okay,
only pain.
okay. I will check the uh, wrist widening and also check the pulse, and I will take blood pressure at the end.
Okay.
Okay, then I go to the head. I want to see the any fontanelle open or not.
Uh, yes, this is widely open.
Okay, then I want to see the eyes, any blue discoloration, any pallor, any jaundice.
No,
Okay, then I want to see the mouth for any dentition,
dentition is
delayed
poor.
dentition.
Poor dentition.
Okay, then I want to check for the neck, any swelling.
No.
Okay, then I come to the chest, and then as I am looking, he has a Harrison sulcus, rachitic rosary, and anything on auscultation, any crepitation.
No.
And on auscultation of the heart, is there any bonding, any added sound?
No.
Okay. And then I will do the abdominal examination to see any hepatosplenomegaly or any stigma of chronic liver disease.
No.
Okay, I want to see any stigma of any scar mark for any renal transplantation, any mass in the abdomen.
No.
Okay, then I want to see the lower limb and any deformity, any scar mark, any joint deformity, swelling.
You can see in that one.
Okay, uh, okay. I want to, in order to complete my examination, I want to take blood pressure. I want to plot height and weight on sundial chart and also OFC. And I want to take intermalleolar distance. And also I want to plot development assessment of the child. Okay, I have examined 2-year-old Jack, who is looking well, but having a height of 68 centimeter. That seems to be low for his age, but I would like to plot on centile chart. And he has upper to lower segment ratio is 1.1. So it seems to be proportionate short stature. He has no stigmata of chronic kidney disease and chronic renal, chronic liver failure. Although he is pale and having wrist widening, having ricketic rosary, Harrison sulcus, and uh, a poor dental hygiene, and
Dental
other.
health.
Mhm.
Poor dentition, not
6
dent.
minutes finish, 3 minutes left now.
Okay. Okay. Present your impressions.
Yeah, my
Differential.
differential could be he is a case of ricket, which could be primary vitamin D deficiency, could be due to malnutrition, poor oral intake, and then it could be a case of
So, how many types of rickets?
rickets. We have vitamin D dependent and vitamin D resistance, nutritional, and chronic liver disease, anticonvulsant drug induced, and we have hypoplastic, hypophosphatemic rickets, and we have.
So, what labs would you like to do?
I want to do calcium phosphate, alkaline phosphatase, and vitamin D level, a parathyroid level, a vitamin D 25, 120, 125 hydroxylase, and also doing 1 hydroxylase deficiency. And I want to do X-ray skeletal survey and to see this wrist, the epiphyseal widening, cupping, and fraying, and also see
FAC you
the
will see on the skeletal survey or what?
which thing.
This one widening and cupping, fraying, and
We can see the epiphysis of the long bones, just like
okay.
radius,
So, how will you manage?
and we will do DEXA scan. Okay, I will involve a multidisciplinary in, history. If he has any acute issue, I will admit the patient. I will involve my consultant. I will send the investigation, and I already mentioned, and I will take a history to find out the cause of his rickets, and then I will involve multidisciplinary team involving my pediatric consultation. Sorry,
How
pediatric
can
consultant.
how can you differentiate between nutritional rickets and X-linked hypophosphatemic ricket clinically?
The nutritional, he has just like he has pallor, he has generalized finding of rickets, upper and lower limb, And but in X-linked, mostly they are the girls. And second thing, they have a marked ricketic changing on the lower limbs as compared to upper limb.
Very good. So what is the treatment in X-linked hypophosphatemic ricket?
We are giving calcium, vitamin D, and phosphate supplementation in higher doses.
Okay. And what is vitamin D dependent ricket?
There are two types. One is this 125 hydroxylate deficiency, and other is having alopecia along with having along and this vitamin D receptor insensitivity.
Okay, and organ resistance. So what is the treatment of alpha-1 hydroxylase deficiency? What treatment you will give?
We can give them calcitriol. That's
Okay.
the most active
What
form
will
of
you
the.
give in end organ resistance? That is vitamin D resistant or type 2 dependent. What will you
Yeah,
give?
we also give the calcitriol this drug, but the dosage is different. So according to the response, we can titrate the dose.
Okay. Okay. You have done nicely for my side. If just I want to tell that if the child will be old enough, that was only 2 years. That's why not for you. Just I'm telling. This is not for you. Just for all. If the child will be old enough, then you will have to do the short station maneuvers as well, and you will have to check the hypermobility as well. Okay, the both things can be in rickets. But the child was 2 years. That's what you have made. Okay, no problem. And rickets, they are disproportionate short stature, and if they are giving you not the ratio, just I'm telling you, if they are giving like which I have given you, the upper segment is 38 and the lower segment is 30, so minus is 8 centimeter. So this is coming short stature. If minus between the upper and the lower segment is less than 7, this will we conclude it as proportionate short stature. Okay, and if it is more than 7, then we will label it as disproportionate. So this was the disproportionate one thing. Otherwise you have given each and everything about labs investigation, and what else I have asked you. And uh, this one not calcium in X-linked hypophosphatemic. You have told me three things like phosphate, vitamin D3, and calcium. Now we are giving calcidiol.
Okay.
And other things that which we have discussed yesterday also, though less likely, but we should consider of further that child is paler, so consider of celiac screening. Okay, and one you told me skeletal survey for the cupping frame. No, that is x-ray wrist of the left hand, not skeletal survey. Okay, so just for good impression you can say about, I would like to go for the bone profile like calcium phosphate, alkaline phosphatase, PTH level, and the child is paler. And I will think of celiac serology also, but discuss with my consultant. And X-ray wrist of the left hand, and DEXA scan, and bone scan, and the other things which can be associated with the rickets. But that will be after discussion with my consultant, like the LFTs, RFTs, or vitamin B12 and folate level. All these can be discussed with the consultant. Okay, clinically difference you told me very nicely, because in X-linked hypophosphatemic rickets, most are the lower limbs affect or skull deformities or dental abnormalities are mostly, and they don't have usually seizures or tetany or stridor, because that's why they are not giving calcium or something like this in this particular. Okay, so what else you told me? Yeah, other things and organ resistance you told me, that is we are giving two things: high doses of calcitriol and large doses of calcium for longer periods. That can be given also. Otherwise that was okay for me.
For the treatment of X-linked hypophosphatemic rickets, only phosphate or calcium and vitamin D also we will give?
Vitamin D3, calcidiol, alpha calcidiol means, and oral phosphate we are giving. He has told me this. And one in the picture, Dr. Yasser, you forget this one to tell about the, see the knee joints also, they are deformed. And the belly is also, this is we called pork belly, yes, protrudent abdomen, especially in rickets. Yes or not? Maybe I can be wrong, but I think
Yeah,
this.
due to hypotonia, I would want to say, but I'm finding where I can put this ankle swelling. I told this ankle
No,
swelling.
no,
I
no,
told.
no. Knee joint swelling is also there. And abdomen, see this abdomen is protuberant. So this is kind of port belly abdomen,
Okay, okay.
visceroptosis kind of. So this finding you should tell.
But actually, sorry to say, in rickets, there is no joint involvement. Only there is a mineralization problem. That's the reason I was confused. Okay, why we have joint deformity in rickets? That's the reason I did not mention anything. And you know, this left leg is
If,
bent and right leg is, so I did not compare exactly the
yeah,
both
we
of
can
them.
tell if you are saying we can tell, but I know they will not ask you so much things. But for our purpose of learning, we are telling each and everything.
Yeah,
But
yeah,
still,
yeah, no problem. Okay.
No, the widening here, even in the knees here, the widening reason is the same thing. Like the lower end of the bony changes, like cupping, fraying, broad, uh, like what happens here, right?
Yeah, yeah.
The same reason. The cupping, fraying, and
But
broad.
joint deformity, regarding joint deformity in rickets,
this may be due to this and epiphysis
Changes, yeah, this
swelling
is
is
what
there.
I'm telling.
Yeah, yeah.
Broadening, it is not broadening can cause you the appearance
This
like.
is yeah, not deformity. This is kind of broadening is there. You can
Yeah,
say like
and
this.
also here we should remember one sign here in the limbs. You can get double malleolus. Means in the malleolus you can have a groove. Okay, like this. You can palpate two malleolus with a groove between them. Okay, this sign we call it as Marfan's sign. You should always check here in the leg. That is one of the clue for you for the rickets. You can tell it as double malleolus. Okay, if you don't want to, if you think that Marfan sign will be confusing, just say double malleolus. That has to be checked, and always here comment on the wrist for wrist widening and other things. Okay, but I want to tell you, Dr. Adnan, since this child was walking, means he was not a bedridden child, right? When he asked, is he able to walk? You said, yes, he can walk. He had delayed walking, but he is walking now, right?
I did.
Huh?
His walking was waddling, broad based.
Problem, waddling or whatever, but he's walking. That means he's able to
Yeah.
stand. Then we have to do
Yes.
short stature maneuvers in him. We have to ask him.
Short stature, 2 years, I don't think so he can do, but like a general physical examination, like stand and walking, then we can check for front, back, and these things which he forget. But if he can do, we can ask him if he
Their
can do.
mentality will be usually good, right?
Yeah, mentality will be good.
If they are
We can
cooperating.
ask him, examiner, no problem. He is 2 years old and he can stand for me. So I would like to go for the short station maneuver if he can follow me or not.
Yeah,
Like this, you can ask.
yeah, you can do that because it is very important here. Now, very nicely you said that if the upper segment and lower segment ratio is given, if it is less than 7, it is normal. More than 7, it is disproportionate. Uh,
Yeah,
but
sometimes they can give you like this.
is there any age limit here?
No, this is rough. This is, I will, Dr. Noor, I will tell you, this is roughly, I have studied, maybe from Nelson or from where. This is roughly, because sometimes they are not giving this ratio. Okay. They can give you upper segment is this centimeter and this is this centimeter. So we can conclude. So I have checked from so many in the Google and other things. They have not given the range. They just have said that if this is more than 7 centimeter, then we will label it as disproportionate.
Okay, okay.
Okay.
Before going to the next case, since Dr. Yasser was this role play, sorry, candidate, I want to ask him, like vitamin D dependent rickets type 1, what is the bone profile picture you will see in them? In type 1, Dr. Yasser?
Okay, yes, sir.
Please open your mic. Hello?
Yeah, I
Maybe
am thinking.
Mm.
Yeah,
Type 1, what
calcium.
is the-
Yeah, calcium and phosphate will be low, and alkaline phosphatase and PTH will be high. While this vitamin D and 125 vitamin D is low.
Okay, in vitamin D, 25 hydroxylase will be normal, right?
Yeah.
25 hydroxylase vitamin D will be, sorry, 25 hydroxy vitamin D will be normal, 125 will be reduced because the defect is in the enzyme, 1-alpha
120,
hydroxylase in
yeah.
the kidney, right? So this is
Yes,
other
yes.
things, the calcium can be normal as well as low, can be normal or sometimes low. Why the calcium will be normal despite the vitamin D is low here? In all rickets, calcium can be normal or low. What is the reason?
because they causing this bone resorption, and bone resorption try to maintain the calcium.
Yeah, that means increase in
Because
parathormone.
there is there is parathyroid, hyperparathyroid,
Yes.
and
So
this parathyroid causing bone osteoclast to release the calcium.
yeah, so in general, hyperparathyroidism is causing calcium normal despite vitamin D is deficient. Calcium is normal because of the parathormone, and phosphorus will be low, right?
Yeah.
It is common for all rickets is alkaline phosphatase high, right? This is the common point for all rickets. Only vitamin D levels will change actually. If wherever parathormone is raised, calcium can be normal or sometimes relatively reduced, you can say, not reduced because of this parathormone, but phosphorus will be
Low
raised.
or normal.
Phosphorus usually will, calcium is raised, phosphorus is less.
Yes, because the kidney excretion is more.
See, actually, in whatever may be your diagnosis, they will ask you the bone profile picture. This is very important in rickets. Okay. Next, for type 2 vitamin, what you see in type 2 in bone profile, vitamin D dependent type 2.
Yeah, here could be, calcium will be low, and alkaline phosphatase will be high.
Okay.
And vitamin D is normal, but vitamin D1 to this kidney one will be very high because there is a receptor dependency.
Yeah.
In response.
So vitamin D3, what we call it as D3 calcitriol, right? 125 hydroxy cholecalciferol. Okay. It will be too much high levels. And calcium can be normal or reduced, and phosphorus will be reduced, parathormone will be increased, and alkaline. Everything same except vitamin D3 will be increased. Very important. Now in hypophosphatemic rickets, vitamin D will be normal, right?
Yeah.
Calcium
Normal, phosphate low, alkaline phosphate is high.
okay.
And vitamin D is 25 normal, but 125 is low.
Okay, what's the reason why 125 is low here? In hypophosphatemic rickets, 125 is low.
Yeah.
Why? I don't know about it. Dr. Adnan, you can tell. Maybe your mic is closed. I think all other than alkaline phosphatase will be raised. As the name suggests, hypophosphate will be low. Calcium can be normal, and also vitamin D can be normal.
I will tell you actually in X-linked hypophosphatemic rickets, problem is FEX gene, PHEX gene. Okay, that is normally this gene is required for the endopeptidase. This is the enzyme which break down the FGF23. Okay, fibroblast growth factor 23, FGF23. When there is mutation in the FEX gene, so endopeptidase will not be more or will be decreased or will not be insufficient. So FGF23 will increase. Okay, this is no more is producing, no more is breakdown. So that can inhibit the activity of alpha-1 hydroxylase. So that's why alpha-1 hydroxylase will be deficient. Okay,
So,
this is the one reason.
so
And the
vitamin D will be less.
other is this increase FGF23 can cause excessive loss of phosphate. That's why there is hypophosphatemia.
Okay.
Understand?
Okay. So we can also see rise in calcitriol and reduced phosphate.
Reduced phosphate and alpha-1
reduced-
hydroxylase will be low.
So calcitriol will be reduced again.
Yeah.
Calcitriol
These are the two
reduced.
things. Yeah, it is FGF23 has two effects. One is excessive renal excretion of phosphate. That's why there is hypophosphatemia.
Okay.
And despite hypophosphatemia, you are right, there should be more calcitriol. But again, this is inhibit the activity of alpha-1 hydroxylase. That's why there is 125 hydroxylase vitamin D3 level is low, despite hypophosphatemia. Even there is hypophosphatemia, but the level will be low again because this is inhibit the activity of alpha-1 hydroxylase.
Okay, I got to know.
Yeah.
So now in rickets, you can get this one is the nutritional rickets, which will be usually less than 5 years old. Okay. And another thing is you will get vitamin D type 1, vitamin D dependent type 1. Here, usually if the children is given age 10 years and all, just think of vitamin D dependent type 1 or type 2. Okay. So now how do you differentiate? What is the clue for you whether this is type 1 or type 2?
Alopecia.
Yeah, alopecia will be the clue for you. If
Alopecia is in type 2.
Alopecia. And he's 12 years old and severe deformities. I don't think nutritional you will allow to go so severe. You will manage, right? So here comes the vitamin.
Yeah, definitely.
And as in hypophosphatemic rickets, usually I think always we should also ask about when we are asking about the surroundings. We can also ask, is there any family member who has come with him who has the same features? We can ask this. Okay, this is a very important clue for hypophosphatemic rickets. Okay, especially mother. Okay, because this is X-linked dominant.
Hypophosphatemic X-linked dominant 80%. There can be autosomal dominant hypophosphatemic ricket in 20% patients.
20%.
Okay.
But anyway, asking the family.
And vitamin D dependent rickets or resistant ricket, both are autosomal recessive.
Yes, and also in the vitamin D resistant, right, there is some autoimmune component, right?
Yeah. That's the reason they have alopecia.
Yeah, this one, yeah.
Vitamin D dependent type 2 has an autoimmune component. So we can also consider searching for any autoimmune diseases also in these patients.
Yes.
Okay. Okay, I think good discussion. We'll go to the next case.
Next I will do or what?
No problem. I will give now.
Yeah.
Can you see?
Yes, I can see.
Okay. This is a 6-month-old child, Anna. Okay.
Oh,
She is not moving her right limb. Okay. Do the general physical examination for her. Okay. This is the second picture for her in the universal Q given to you. Okay. You can see the second picture.
okay.
Okay. This is she, and this is the second picture. Okay. You can, I will give you 2 minutes and then you can start.
Yeah, yeah.
Start.
Okay, I will greet parents and introduce myself, take permission for examination. After wash my hand, will see the patient for any sick looking, well looking, or alertness. Anything, then I would like to check in the surrounding for any mobility aids or anything, and would like to check on the face for any unusual features, and would like to check for if he not wearing the glasses at the moment, is there any hearing aid? So is there any finding?
Yes, she is in pain, crying. Otherwise, no unusual features, nothing in the surroundings. What else you
Okay.
want to ask?
And crying. Okay, then I would like to check his height, weight, and head circumference as well.
Length. Okay, weight, length. Okay, weight is she's going on 25th centile. Okay, length is she is on 25th centile as well. But she's not keeping her leg straight, the right one.
Okay, so now I would like to go for general physical examination.
Mm.
So first of all, I would like to expose the child, ask the mother to expose the child by keeping the modesty of the child in mind. So
Okay.
I will do the general examination as child is just 6 months old. So on the bed from the three sides, from the right side, left side, and the foot and side, and from all side, I would like to check for is there any bruises or any ptichiae, or is there any swellings of the joints or bones or muscle atrophies or hypertrophy or any asymmetry, and anything is there?
Yes, bruises is there in the right thigh.
Okay,
No
so I
other.
would like to check this is these bruises, how many bruises?
Okay, one big
Just one,
bruise is there on the
one big
anterior part of the right thigh.
interior part of the right thigh. How much centimeter this one?
7x7.
Okay, so then I would like to, after doing the general inspection on the back as well, I would like to check, but as the child is crying, so I will defer at the moment. So I will start my examination from the hands, looking for leukonia, chylonichia, or any clubbing, cyanosis, pallor, or
No,
any bruises,
nothing in the hand.
anything is
Nothing in the hand.
okay. Would like to check the at the wrist level of the wrist. Is there any widening of the wrist or any on the
No
arms any
widening.
bruises?
No widening, no bruise.
Okay. Okay. Brachial pulse. I would like to check the brachial pulse. Pulse is normal.
Yes, pulse is normal.
Okay. On the head, I would like to check for shape of the head, size of the head, and any sutures and shunt or Anything is there?
No, the side,
Any scar?
no shunt,
Any
no
scar?
scar, nothing. The head is
Okay. So in the eyes, I would like to check for pallor or any redness of the eyes or anything is there.
no pallor, no redness.
Okay, then I will move to the face for this mouth, looking for poor dental hygiene or malocclusion of the dent or poor dentition. As this is
Months
just six
old,
months.
6 months
Yeah,
old,
this is
no
just six
dental, no
months
dental.
old. So I
Okay.
would want to check this if there is any dentition is there or not, or any high arched palate or anything.
No, 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 no. Okay.
In the ears, would like to check for any hearing aid or anything.
No,
Okay, so in the neck, would like to check for any scar, any swelling, anything.
no,
So then I will move to the chest for looking for any scars or any deformity, anything or any swellings or any portacath or anything is there.
no.
Okay, then we'll move to the abdomen. So I will check for the first and second heart sound as well, and any added
Normal.
murmur is there, auscultate. Then would like to go for abdominal examination on inspection of the abdomen. I would like to check for any scars, stria, or uh, any visible veins, and will palpate for any hepatosplenomegaly, any mass.
No, no findings in the
So
abdomen.
then I will move to the lower limbs. So as the child is not moving his right thigh, so I will be very much careful as child is already crying. So I would like to check just for joint. Is there any joint swelling, obviously,
No,
or
no,
any
no joint
erythema?
swelling, but there is swelling in the mid thigh. There is swelling in the mid thigh and also bruise over the same area. And the child is not moving, not at all moving the right lower limb.
Not moving the right lower limb. Okay, so for this swelling, if you will allow me, I just want to check the temperature of the swelling, and if it is high temperature or anything is there.
No, no, the temperature is not high, only it's like a bruise.
Okay.
Okay.
And
Explain and finish.
so in
In
order to
order to
complete my examination, I would like to check on the back as well, but I did not disturb as the child was crying.
okay.
So I would like to do the fundoscopy of the child as well, and will like to take the history and check his previous notes as well
Okay.
about
History,
this.
vitals,
So this is
vitals and check previous
and
notes. Okay.
his vitals as well.
Okay. Tell me your differential
So
diagnosis.
my differential diagnosis. First of all, I will think of non-accidental injury, accidental injury, and I will think of osteogenesis imperfecta as well.
Can
But
you please
I have not
ask
found any.
for clue for osteogenesis imperfecta in your examination?
There was no specific clue was given, as there was no blue sclera in the eyes, and there was no,
Okay,
I
but you
mean to
did
say,
not ask
hearing
particularly
aid.
for blue sclera. No problem. Okay. Then
And there was no multiple fractures was there, and so
what is your
yes.
in investigations and management for this child? Investigations and treatment for this child. What do you want to do now?
So first of all, as the child is first of all, I would like to involve my own consultant for child protection duties. Okay.
Okay.
So this one, after involving this, then if the child is all in urgent life threatening, then I will have to start necessary emergency treatment. And as the child is crying, so paracetamol maybe due to this pain, as I can see in the X-ray, there is a fracture. So for paracetamol can be given, and definitely refer the child to the trust protection teams,
Okay.
and and also the social worker and the police can be involved here, and this will be all be discussed with my consultant, and will also consider of the risk of other siblings if in the family is there. And I would like to
What
counsel the
investigation you
parents.
want to do?
Yeah, first of all, investigation would be skeletal survey, and the child is less than 6 months. So I would see for CT scan as well, and fundoscopy. And there was a bruise, so we'll consider of CBC and blood film and coagulation profile, and the factors like 8 and 9 also will consider for that also.
Okay. So what? How do you want to manage? You said
And
you
also
involve the.
bone profile.
You said
Also
you.
bone profile. And if it is osteogenesis imperfecta, so I will have to check for just 1 minute. Sorry, telephone is coming. For my night duty, they are calling me. Okay, no problem. Okay, so
Okay.
uh,
Okay. Tell
yeah.
me. You told the
So when
investigations. Now tell the management. You already told me consultant and social service. Apart from that.
so first of all, I have to take the history from the parents, and if there is previous notes are available, this similar kind of or any visual recording is available, so I would like to check for all this also. And then I have do the examination, as already I have done the examination, and would like to check the further examination of the like uh, what this is frenulum of the lips and the tongue
Yeah. You
can
will
be
do
checked.
head to toe
And
examination for
yeah,
non-accidental
head to
injury
toe.
research.
Yeah, for the non-accidental injury,
Okay.
and
Already
would
you have
like.
done. So now what is your management here? Anyone you want to involve now? You will involve the
Yeah,
orthopedic.
for that, this my multidisciplinary team. So first of all, because I can see in the X-ray there is a fracture, so I would like to involve the my consultant as well as orthopedic surgeon urgently.
Okay.
Okay. So according to that, the further in management will be like may need occupational therapist, physiotherapist, and child needs to be admit in the hospital. Okay. And anesthesia team, and what else? I don't remember now
Okay, no
further.
problem. No problem. I want to, okay, finish your discussion, finish now. I want to tell you something. Mashallah, you did well. But the thing is, when you are answering, if you answer like this, in 3 minutes, you will not finish the answers. Okay, now you got to know already that you have examined already. The examination part is given. First I will give the feedback for your examination, then I will tell you. Now
Okay.
in this case you are seeing a 6 months old with femur fracture. So already in your mind the differential, one is non-accidental injury, the second will be osteogenesis imperfecta, right?
Okay.
So
Yes.
you are
And
examining.
also, I will think accidental injury. I will think also there can be
Okay,
accidental
but
injury.
less likely accidental injury. This child will not run or anything.
Yeah,
Uh,
yeah, very less likely. Yeah, yeah, yeah. You are
Very
right.
less likely. So non-accidental and osteogenesis imperfecta you will put on the top. You can say very less likely unless the child is mobile. For a 1 year you can put. He has
Yeah, yeah,
started walking, or what is this? Crawling like this. 6 months and less, very less likely. So in your mind,
yes, yes.
non-accidental injury. So when you are examining in head to toe, you have to search for non-accidental injury findings. Okay.
Yes.
So when you asked, be careful. When the child is less than bedridden, ask for length, not for the height. Okay. Tell
Yeah,
length. This is very important. And you are asking mobility aids when this child is still not mobile. You can ask anything
yeah,
in the surroundings only. No need to ask particularly as mobility aids. This is one problem. Like definitely the child will not communicate with you. For well communicating, you can say that I will observe the child. Is the child alert,
no,
moving?
no, I did not say well communicating. I think I
No, no, you
said
did
that.
not tell. I know that. You did not tell. I am just telling
Yeah.
general approach.
Yes.
Okay, for
Okay.
this child, we will just say you said alert. That is right point. Whether he's alert or not, he's crying in pain. This
Yes.
is told to you. So before starting your examination, you told that you will observe the child from all the sides. This was told to you, but you have to tell particularly you will observe the child for the movements. Like usually small children, what they do, when we see if they are happy, they will be moving all the hands, legs and all, right? So you
Yeah.
will, along with the observation, particularly you will tell that whether you will observe for the movement, whether he's moving both the hands normally or not, both the legs and neck movements, whether the child is doing or not. Because you can suspect any injury all the body. So just add that from all around you will observe for movements as well, along with other inspection parts. Okay, observation of movements of all parts of the body. So if you tell that, your finding will be given to you that he's not moving the right leg, except everything he is moving. So when you come in the eyes, particularly you have to ask is, I am seeing blue sclera. You did not ask this. You told just
Yeah.
pallor and jaundice, maybe something you asked, but you did not ask blue eyes. Or
Yeah. Blue eyes. I did not ask. Yeah.
no, not
You are
blue
right.
eyes. We will ask blue sclera in particular. Be
Yes.
particular, because this is osteogenesis is your differential diagnosis.
Differential. Yes.
Then after coming to the face, okay, mouth, you should ask any in, after asking all these high arch palate, cleft lip, cleft palate, whatever, you should ask, is there any frenulum injury in the mouth? I particularly want to check. Okay. This is very important. You have to ask for frenulum injury in the mouth. In the chest, along with that, you will say that after examining for the deformity and also auscultate for the heart, you will tell that I will particularly try to palpate if there is any ribs injury in the chest. Okay, ribs injury in the chest. And then for abdomen, just palpation and see for bruises or anything in the abdomen as well. In order to complete my examination, always you, if you don't see genitalia in this child, you can offer, because this is a small child, or at least offer in order to complete, just to see even there is no injury in the genitalia as well. Okay. Then in the limbs, you have to observe and describe as told. There is swelling in the mid thigh with the bruise. Okay. So in order to complete my examination, it was very good. You told fundoscopy, and also you will tell that I will check for in all the signs of non-accidental injury if you have missed anything. Okay. Then differential diagnosis, non-accidental injury, osteogenesis imperfecta, you will put. So one of the important thing is the blue sclera, which you should not miss. When you tell the investigations, I told you before also, let's practice to tell point wise. If we tell long sentences, what happens, we should practice ourselves to answer investigations and management in 2 minutes, because our 1 minute might go in order to complete, and also in presentation, we don't know, right? We should target to answer.
Actually, this my habit is from different, like Dr.
No
Muzna.
problem.
She was speaking too much, so I don't know. And there was one another you don't know. She was also speaking too much lengthy, so that's why. So it will change by time, inshallah.
Yeah, just try to change this only. You gave every information, but they will not give you time more than 3 minutes.
Yes.
Okay, this is what I want to tell you. 1 minute, I will just tell you for
Also, one thing, I did not study this one today. I was just.
No problem, we can just go through quickly, but this is common topic. What you said, everything was correct. Okay. Only thing is, when you are asked for management, when management, khalas, it includes both investigation. So in this child, now from the picture you got to know that, and also by your examination, You got to know that the child is
No,
not.
that one, Dr. Noor, I want to tell. That was orthopedic was in my mind. All of a sudden, this
No, I'm not
telephone
saying
came
for
for my
orthopedics.
duty.
Just listen to me. In management, how do you start? Now, after examining the child, I got to know that the child is in pain. So first I will stabilize him by giving the painkiller. And since I'm suspecting non-accidental injury, I will immediately involve my consultant and the social service or child protection team, whatever. This is finished. This social service will take care of police and everything, right? So your consultant and social service or child protection team you involved. This first step is finished. Now for the child, since this child has the fracture of the femur, I want to involve the orthopedic surgeon first. And also I will do the skeletal survey and I will do the CT brain. So in the CT brain, if there is any finding, I want to refer to neurologist or neurosurgeon. And if there is any bone involvement, already you have involved the orthopedics, right? So orthopedics will be involved and child protection team. This is the main things here. Now rest all depends upon the later point, but your investigations, khalas, they were complete. I don't know. I also did not go through the guidelines. If Dr. Yasser has gone through, let him tell us if anything we missed.
Can we add a safeguarding here?
Yeah, definitely. This is safeguarding.
Yeah, safeguarding means what is written in guidelines, what he told in management. We can go through, just wait. So this non-accidental injury is under the safeguarding here, or where it is?
Yeah, the same.
68. So this is the physical abuse. We'll just go for the management only. So here hematological investigations, as you said, FBC and film because of bruises for leukemia, I think film here, right? And APTP, PTINR, thrombin, fibrinogen levels, if thrombocytopenic, platelet volume. Okay, as you said, factor 8, factor 9, blood group and all these things. And other investigations we told already, that is very important. Subsequent investigations only if you are suspecting these problems in the basic. Otherwise, you will not go for that.
Yeah.
More than that, this we should know. If there is personal history of abnormal bleeding or family history, you will involve pediatric hematologist. Otherwise, biochemistry will also involve this bone profile. If there are unexplained fractures and also suspected abuse, then skeletal survey in children aged less than 2 years and head CT scan in children aged less than 12 months. Further neuroimaging according to the guidelines. Document in notes if decision not made to proceed with imaging. Photographs, often police photographer is used. So when immediately, I think we will involve the child protection team here. Record findings accurately during and immediately after examination using a dictated child protection pro forma. Here, I think here is given the immediate action. This one, immediate action. If there is urgent or life-threatening situation, start necessary emergency treatment. Refer to your trust on-call child protection arrangements. As you said, child protection. If you suspect harm, refer to social care and police if they are not already involved.
कोई बात
Keep any
क्या
social
हुआ?
worker and police officer involved informed and potential risks of, you told all these things to siblings,
Yeah.
police officer, social care, child protection team. I think from investigation and management wise, it's okay, but you should practice to tell fast in points in 3 minutes. This is the thing. Okay. So it was fine. We will go to the next. And always we should remember the head to toe findings in non-accidental injury so that we can check for them. Okay. You checked very well in the head for any swelling. Head was checked very nicely, but the only thing you missed was the frenulum, and particularly checking for rib fractures in the chest. This was the things missed. Otherwise, blue sclera, these 3 things you missed from my side. Okay, maybe if I read later, I may get some point. Okay, you can give the command to me, Dr. Yasser.
Yeah. 2-year-old John presented with the short stature, do general physical and the relevant.
2-year-old John presented with short stature. Okay. I will just take 2 minutes. Okay, once I finish, I will tell you.
Okay, no problem.
Okay. Good morning. This is Dr. Noor, one of the children's doctor in this hospital. After introducing myself and washing my hands, I would like to examine John. First, I would like to communicate with him to check whether he is well communicating or not, and also whether he is well looking, not in distress.
Yeah, good speech, good communication, and well looking.
Well looking. Okay, I want to check his weight, height, and head circumference and plot on the appropriate growth chart.
Weight and height less than second centile, and OFC also less than 25th centile.
OFC 25th centile. Okay. Now I want to check the mid-parental height centiles and plot, and also check the sitting height for the child.
Yeah, upper and lower segment ratio is 0.7, and this one mid-parental height is on 25th centile.
Okay. So this baby looks to be short in short stature. I want to check whether is the child walking.
Yeah, he can walk, but
Yeah,
with limping, some limping.
okay, some limping is there. So since he is 2 years old, I will try to give some commands if he's able to follow. Like if I ask him to bring the hands and feet together, can he do that?
Yes, yes, he can.
So is there any asymmetry?
No.
Okay, now I want to check from the side for any kyphosis or any where the limbs are reaching for his side thigh.
Yeah, up to the thigh it can reach.
Up to the mid thigh. Okay, now I want to check for the back for any scoliosis. I think that he has scoliosis from the universal Q.
Yes, yes, he has.
Okay, and also I ask him to bend forward to touch the ground. Is he able to do?
No.
No, he's not able to do. Okay, so now I would first like to means describe the universal Q before going to the examination. In the universal Q, I can see that the child has blue sclera, and also there is some poor dentition, and there is some deformity in the lower limbs, and there is pectus excavatum in the chest, and scoliosis as well as clinodactyly in the hands. Now I will start as the child, if in the star he is making, there is clinodactyly. I would also like to ask him to make the fist to check for short and fourth and fifth metacarpal, and also look for pallor, cyanosis, clubbing, or any findings in the hand.
No, nothing.
Okay, so now I want to check his pulse and blood pressure.
Normal.
Okay, I would like to ask him to put his hands in the side to see for carrying angle.
No.
No, okay. I would quickly like to see the axilla, if there are any findings in axilla.
No.
Okay, eyes already, he has blue eyes. I would also like to check for pallor and jaundice.
No pallor, no jaundice.
Okay, mouth, I want to look for, there is some poor dentition. At the same time, I want to look for any high arch palate, cleft palate, or any other deformities.
High arch palate is there.
Okay, high arch palate. Okay, neck, I want to see. Is there any short neck or anything?
Nothing.
Okay, chest, there is obvious deformities. Now I want to auscultate the chest to hear for the heart sounds.
That's normal.
Normal. Okay, I want to palpate the abdomen and look for any scars or anything, to do superficial and deep palpation.
Nothing is there.
Okay, in the limbs, I can see there is an obvious deformity in the lower limbs, and also the upper limbs. There is deformities in both the arms and the forearms. Okay. In order to complete my examination, I want to do the complete musculoskeletal exam, take the history, vital signs, plot the child on the appropriate growth charts, and do the complete musculoskeletal examination for this child.
Okay. Would you like to explain your finding?
Today I examined 2 years old Jack. He is short for his age, less than second centile, and his missed parental height is on 25th centile, and he has a disproportionate short stature because the upper segment and lower segment ratio is just 0.7. He is walking with difficulty. There are multiple deformities in his upper limb and lower limbs, and there is pectus excavatum in the chest and scoliosis in the back and poor dentition and blue eyes and clinodactyly in the hands. With these findings, this is a case of disproportionate short stature, mostly a case of skeletal dysplasia. My top of the differentials will be osteogenesis imperfecta.
Okay. What will be the other differential?
Can be rickets. I can put rickets as the other differentials, and other skeletal dysplasias like achondroplasia, but less likely in this case.
Okay, 6 minute finish. No
Okay.
problem. Okay, how will you manage this child?
Yes, this child, I want to do some investigations to diagnose the child. So I will consider genetic testing and also examine the complete clinical features for the child and involve the geneticist for the genetic testing. And also I would like to involve the orthopedic team because they have multiple deformities, and physiotherapist for the physiotherapy. And the most important treatment here considered will be bisphosphonates.
Okay. What advice you give to the parents?
Yeah, I will give advice to the parents to avoid the vigorous activities because their bones are very brittle. They can have multiple fractures. Okay.
Okay. Next.
And also they can have some problems in their brain. There can be some compression on the spinal cord. So we have to refer these patients to orthopedics or spinal surgeon, neurospinal surgeon.
What the multidisciplinary you told? Can you repeat? Sorry, I did not understand.
Yeah, multidisciplinary team is the orthopedic team, physiotherapy, occupational therapist, okay, pediatric consultant, and also sometimes they can have cord compressions. So I want to involve the neurologist and the neurosurgeon, and they can have anesthesia related problems as well.
Okay. 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 You did fine. Regarding this, first of all, advise the mother if they found antenatally, so they have to go through the C-section. Second thing, as you told, contact service sports they have to avoid. Third, this manipulation, and fourth is genetics.
Can you tell again?
First is this one. For the next next child, if they found the patient has the child baby has antenatally he has osteogenic imperfecta, so they have gone through the cesarean section.
Okay.
Second, avoid contact sports, as you told. Third is manipulation, easy manipulation, and fourth is genetics.
What do you mean by easy manipulation?
Allah, it means they have to
Easy
carefully handle.
manipulation.
Means I should
Easy
handle the child
manipulation.
carefully.
Yeah.
This one is.
Okay, very. I should know that he has brittle bones, so I
Yes,
should
yes.
handle carefully.
I,
Okay.
I will tell one more thing.
Uh,
While whenever you are examining this osteogenesis imperfecta, so
hmm,
2-3 things you should tell to the examiner. So these childs have very fragile bones or brittle bones. So I would like to be careful about this. And most of the my examination will be in collaboration with the help of the mother. One
hmm.
thing. The other thing, as they may have hypermobility, for that you should tell that these childs may have hypermobile joints.
Hmm.
I want to check, but as they have very fragile bones, so I will defer it.
Okay, I
Okay,
got your point.
these two things.
Even my
Yeah,
examination, most of it I will ask rather than doing myself because of the brittle bones.
yeah, this one
Uh,
you should tell that. Yeah, I would like to ask most of the things from the mother, because these childs have very fragile bones, so I don't want to manipulate, or I don't want to handle their bones. And in the findings, hearing aids, you should tell that in order to, or in multidisciplinary team, they have problem with the hearing also. So this one you should
yeah,
tell
I forgot about.
audiologist and ENT or simple audiologist.
Oh,
And this one in the lower limbs findings were these are angulations. They
yeah.
have, due to the multiple fractures, they have angulation. So these findings name is angulation.
Mm. Yeah, this is the angulation very clear here. This
Yeah,
one. This one is the angulation. And here also, here what we will describe, this is like this.
these are also angulations.
Okay, multiple fractures with, maybe we can say maybe multiple fractures with angulations.
And see
These are
this
the
big,
these are the, you can say, cured fractures. Whenever there is cured fracture, there is some angulation.
yeah. So this is a picture number F. In lower limbs, see his foot is not reaching to the, so there can be leg length discrepancy, but that can be again due to the scoliosis. So I need to check for that.
Okay, there can be limb length discrepancy. It can be due to scoliosis and also can be due to the deformities like this.
Yes, so you should tell about this.
Okay. So I asked about bending, but for all these things, I will tell I will be very gentle and take the help of the mother. Very
Yes.
important this point.
And in the laboratory exam, as you said, that genetic testing, and one more thing, they, okay,
The
genetic
skeletal
testing they
survey.
are doing, skeletal survey and urine they are doing for 24-hour hydroxyproline.
Okay. Skeletal survey I missed. Genetic testing I
Skel-
told. Then
Genetic testing, skeletal survey, and 24-hour hydroxyproline they are doing. And also I would like to involve the audiologist to check for formal hearing assessment in the laboratory. And for the blue sclera, I don't know they are involving ophthalmologist or not. I don't know.
okay,
No, there
audiology.
is no vision problem.
Okay.
Sclera is due to collagen issue, but there is
Yeah,
no
yeah.
vision problem.
Okay. Then the laboratory is will be 24-hour hydroxyproline in the urine, and genetic testing and audiologist for the hearing, formal hearing assessment, and skeletal surveys.
Okay.
So there is no definitive treatment is not there, but high dose of bisphosphonate they are giving. And some authorities are saying for calcium and vitamin D, they are also giving for the good mineralization of the bone.
Okay. And what is the role of bisphosphonates is to inhibit the osteoclast activity and stimulate the osteoblast activity. That means it will strengthen the bone.
Strengthen the bone.
Yeah.
Osteoclast is when resorption is there, osteoclast are forming. So this will inhibit bisphosphonate. And osteoblast is when bone is formation. So this will enhance the bone formation. But again, for the formation, when bone is forming, we needs good mineralization with the calcium and phosphate. So for that, we need vitamin D also.
So yeah,
That's why they are saying.
along with bisphosphonates, vitamin D, calcium, and phosphorus supplements.
Yeah. So another what I want to tell, forget. It was in my mind. Just ideologist we have done.
Okay,
Team
let's
you have
list
selected.
the team again. You will remember. So pediatrician, orthopedics, audiologist.
Yes.
Occupational therapist,
Occupational physio.
physiotherapist.
physiopsychologist,
And also I told you for the spinal problems, you can also involve the orthopedician and the
Yeah.
and the spinal surgeon also.
So there are how many types?
8.
I believe we are just studying 4 types in our MRCPCH. This Nelson they have written 8. I know.
No, in here Mark BT also written 8.
Yeah, they have written also 8. Yeah, you are right.
Number they have written, but mention only 4.
4. Because they have studied about 4 only. So
Yeah,
just
yeah.
to memorize, 23 is bad. So just how I am remembering, always 23 is bad, 41 is good. So 1 and 4 they can be mobile. They can be mobile, and they have less complications. And the fourth is not having blue sclera, 1 is having blue sclera. So 23 is bad, means they usually 2 is very severe, they don't survive. 3 may survive, but bedridden will be there. And if you are thinking in the exam this is a type 3, so never ever touch the patient. Just tell that I want to ask from the mother things. Okay.
Okay. So I will again tell you, because this is very nice you told. Okay, 41, 23 is 41 is good. That means they can they are good and they can walk. And also in that I think 1 has blue sclera. And 23 is bad. Usually the type 2 will die. And type 3, even if they survive, it's a severe brittle bone disease. So better not to examine, ask the questions from the mother. Okay.
Even Dr. Mutaz was telling, there was one candidate when she entered and she saw the scars and everything, and the patient is in pain. She said, I cannot examine that patient. And the examiner was crying, shouting on the candidate, and was saying, why you are not doing, why? He told he is a case of osteogenesis I cannot give him more pain. But he passed the candidate, but he pressurized the candidate to force to examine. So he said, be careful, such type of situations.
Okay. Okay, we can go. No, only one case is remaining.
Continue now.
Okay, yeah, I will share now. I will share the picture.
Okay.
Okay. This is a 14-year-old girl, Janelle. She is presenting with delayed puberty. Please do general examination for her. Okay.
Okay.
two minutes and then okay. We go.
Inshallah.
Start.
Okay. I will enter the room, wash my hand, introduce myself to the journal, get permission for examination, and expose the child. I want to see if there anything in the surrounding.
Nothing in the surroundings.
I want to communicate with the journal to check his speech and mentality.
Yes, she's communicating with very difficulty. She has low mentality.
Okay, then I want to see some dysmorphism. I will explain later on. Is she in distress?
No, she's not in distress.
I want to take height and weight.
Okay, her weight is on second centile. Her height is on 0.4th centile.
Okay, OFC.
Normal. 20.
Okay, and mid-parental height.
Mid-parental height is on 25th centile.
Okay, and then is the patient is in distress, looking well or ill?
Not in distress, looking well.
Okay, then I want to check the gait of the patient.
Okay, she's walking normally, no problem.
Okay, then I ask her to sit down, and I want to take her upper segment and lower segment ratio.
Okay, upper segment and lower segment ratio is 1:1.
Okay, then I ask her to keep her palms to my side to look for any simian crease. Then I want to check any clubbing, any contracture, any clinodactyly, any. Then I ask her to move her to make a fist, and then I want to check third and fourth short metacarpal.
No, you did not get any findings in the hand.
Okay, then I ask her to put her four hands together and check the symmetry of the hands.
Symmetrical.
Okay, then I ask her to touch her hands to the ground, and I want to see the back to see any kyphosis, scoliosis, and also from the lateral side.
Okay, she has scoliosis but no kyphosis.
Is she touch the ground with the hands?
No, she's not able to touch.
Okay, then I will see his hand to see any hypoplastic nail, hyperconvex nails, any clubbing,
No,
any
it's not
sweating.
there. Not there.
Okay, then I want to check any dry coarse skin.
No, she doesn't have dry coarse skin.
Okay, then I want to check the pulse and check the rate rhythm.
Normal, 90 beats per minute, regular, good volume.
I want to take BP at the end. I want to check axilla for any puberty sign.
No pubertal signs in the axilla.
Okay, then I am looking in the face. She has a prominent forehead, epicanthic fold, hypertelorism, ptosis, prominent and dysplastic ears, and having triangular facies with maxillary hypoplasia. I want to check her neck for any thyroid, any neck swelling.
No neck swelling. Okay.
Okay, I want to see dentition is good, and I want to see back for low hairline or any webbed neck or
Yes,
any,
no hairline and web neck is present.
and I want to check the folds, any extra folds.
No extra folds.
Okay, then I want to check the chest to see the is it shielded, wide space nipple.
Yes, shield chest with wide space nipple.
Okay, then I want to auscultate the heart to see any murmur or any added sound.
Yes, S1, S2. S1, S2 heard there is an ejection systolic murmur in the left upper sternal edge.
Any radiation, any thrill?
Where do you want to check for radiation?
The back.
Okay, yes, it is radiating to the back.
And thrill in the left upper right.
Yes, there is the thrill in the left second intercostal space. Yes.
Okay. Then I want to go to the abdomen to see any scar mark, any visible in soft, superficial and deep pulsation. Is there any mass palpable?
No, no mass palpable.
Okay. Then I check the lower limb, any edema of the lower limb or any joint deformity or any.
No edema,
Uh,
no joint deformity.
okay. In or any petechiae bruises, any rash in the
There
lower
is,
limb.
yes, there are bruises in the shins. That's all. Nowhere, no, nothing other. Bruises.
Okay. In order to complete my examination, I want to take four limb blood pressure, pubertal assessment. Want to plot the centile, this height and weight, and OFC, and also check for mid-frontal centile. And okay, I have examined Janel, 13-year-old Janel, who looks dysmorphic feature, and which could be persistent with the Noonan syndrome. And he has is obvious short stature, and he's proportionate short stature, and he has deformity uh, in the form of a shielded chest from a wide space nipple, having ejection systolic murmur at the left upper sternal border, with radiation to the back, and his abdomen also having bruises in the lower limb on the shins.
Okay. So what is your differential
Sorry.
diagnosis?
Yeah, my diagnosis could be he's a case of Noonan, female varieties.
Tell proportionate short stature.
Proportionate short stature, most likely Noonan syndrome of female variety.
Okay, proportionate short stature in a syndromic child, most probably Noonan syndrome. Okay, what are your differential diagnosis?
It could be a case of Turner syndrome.
Why here? Why did you put your top as Noonan's? What is supporting you?
First of all, this his facial feature, ptosis, dysplastic ears, triangular faces, and having ejection systolic murmur of pulmonary stenosis. So these are the things
Yes,
that
bruises
favors.
also. Okay, bruises also. Okay,
Yeah.
tell me, how do you want to manage this case now? What is your investigations?
Yeah, I will, if there is any acute issue, I will admit the patient, involve my consultant. I will take a history. I will do investigation in the form of karyotyping. And
okay, karyotyping to rule out Turner's.
and
Noonan's,
genetic
what do you want
studies.
to do?
Yeah. And for Noonan, we want to do genetic testing. We want to take CBC to see the hemoglobin and platelets. Then we will do chest X-ray to see the heart status, echocardiography, electrocardiogram for pulmonary stenosis, and also X-ray wrist for bone age, and FSH LH to uh, see for puberty assessment.
Okay.
And then the multidisciplinary, I will take involve my pediatrician to see for complication and congenital anomalies present for monitoring. And then I will involve cardiologist, endocrinologist, this social worker, psychologist, psychotherapist, and inform the school, so audiological and speech and language therapist.
So complete developmental assessment with complete involvement of the developmental team, including physiotherapy, occupational therapy, speech and language. So do you want to consider growth hormone in these children?
No.
Okay. So now she has delayed puberty. How will you manage this?
I will, she's a female, so I will give him estrogen to boost up her. I will involve the endocrinologist and discuss with
Okay.
him regarding the start of estrogen.
Okay. Okay. No problem.
Sorry, I did not
So for
read.
the FBC, what you will do for the only you said FBC and platelets. Anything you want to do? For
Von
the
Willebrand factor. Von,
coagulation profile. Say coagulation. Yeah, along with FBC, you'll do coagulation profile.
okay, okay, okay.
Okay, that's it. For us, only that much. You will do genetic testing for the diagnosis. And you will consider karyotyping to rule out. But if you get by genetic testing the definite, it's okay. And also, what is the recurrence risk?
Sorry, I don't know.
It's very easy. Any autosomal dominant condition, any
50-50.
autosomal dominant condition. No. There is one thing you have to tell here. When they ask about recurrence risk in any autosomal dominant condition, you will tell if parents are affected. Most of the autosomal conditions can be sporadic, right? Or de novo mutations are sporadic. So if the parents are affected, the recurrence risk will be 50-50. If the parents are not affected, it can be less than 1%. I hope you got my point.
Yeah.
Yeah, any autosomal dominant, if they ask recurrence risk, just tell if the parents are affected, the recurrence risk will be 50-50. Suppose the parents are not affected, this is a new mutation, it will be less than 1%. So depending upon parents affected or not affected. That's it. Otherwise, you covered everything. Multidisciplinary team will be geneticist. Whenever you tell geneticist, along with that, say genetic counseling. Geneticist, genetic counseling. Then you said cardiologist, you said endocrinologist, and also hematologist for hematological issues. And they can have developmental problems. And also they can have eyes and ear issues. So you should also involve ophthalmologist and ENT here. Okay, and they should be annually followed for all these things. Thyroid functions, because they can also have hypothyroidism. Okay. And also orthopedic and dental issues also should be evaluated annually. I want to tell you one more thing about the growth hormone. Yes, like Turner syndrome, here also they consider growth hormone therapy for the growth of the height, and also for delayed puberty. In girls, they consider estrogen, and in boys, testosterone. Okay, they are giving growth hormone in these children also. Dr. Adnan, you want to add anything?
No. That was completely good.
Okay, regarding his approach, I marked what he missed. He missed one important point. Did you ask about carrying angle?
Sorry, I forgot. I remembered, but while manipulating,
Yeah, this is what happens. You forgot very important point, carrying angle. Another thing, you did everything apart from that. And what you forgot, you asked some of the questions 2 times. Okay. This will means like you asked well looking, not in distress 2 times. You asked in the starting and again in between somewhere you asked. And you asked about hands, the same pallor, cyanosis, clubbing, something like this you asked 2 times.
Yeah.
Okay. And I want to ask Dr. Adnan regarding this radiation of pulmonary stenosis murmur in the back. Where exactly here? In between the scapula, upper part?
Yes.
Like if this is the scapula, where do we hear? This is
in between the scapula can be radiating.
Like this, pulmonary stenosis.
Yeah.
Okay, suppose this is right side and this is left side. So for the coarctation of aorta here, right?
Yeah.
Okay, and also for coarctation of aorta in the front, where do we palpate? Below the left clavicle.
Yeah.
Because if suppose if this is the heart, okay, again this is right side and this is left side, the aorta will come like this. So whenever there is coarctation, maybe we can hear in this area. So usually below the left clavicle in the front, back in the below the left scapula. So suppose if we are suspecting a Turner's case, always I think we have to ask these points for auscultation, right?
Yeah.
Okay. Okay, Alhamdulillah.
www.ipl www.ipl.high blood pressure clotting factors low leads to bleeding. So you will always remember. W, wide nipples, wide carrying angle, and one W is widely spaced nipple, wide carrying angle, and
Webbed neck.
webbed neck. Okay. IPL is intelligence is low. I, P for pulmonary stenosis you can keep, and L was I
Learning
forget.
disability.
Learning disability. Just and then is high blood pressure. They have high blood pressure, and H is Hocum. They may have Hocum also.
Yeah, they may have Hocum. Yeah, this is the major cause of death in them.
Yeah, so all these features you will always remember.
Okay.
I'm usually remembering like this. Otherwise, you cannot remember.
No. For this, I want to ask you, in Noonans also there will be fourth and fifth metacarpal short.
No,
Okay.
they have not. Just I will see which one I forget. Where is my Noonan? One is web neck, wide carrying angle, and widely spaced nipple, intellectual disability. Yeah, P is for pulmonary stenosis and P is for pectus carinatum can be there. Okay.
Yeah.
And L is for low set ears. They have low set ears. So H high BP, blood pressure can be high, and H is for again Hocum, and they may have branches pulmonary stenosis. B is again for branches pulmonary stenosis, and they have low clotting factor leads to the bleeding.
Okay.
So this is the complete, and all you remember this is short stature.
Okay. And this I want to ask Dr. Yasser, tell the again, describe the facial features again here. You said the broad forehead.
Yeah, prominent forehead. This epicanthic fold, downward slant palpable fissure, ptosis. Okay,
Yes,
this
right?
prominent
Drooping
and
eyelids. This is drooping eyelids is there. So always in the Noonan, drooping eyelids can be there.
Okay, then there are the dysplastic and prominent ears, triangular facies.
Okay, and also they will have low set ears, right? To check the low set ears, we just have to draw the line from here. See, the normal ear should be touching here. So
the tragus.
Yeah, means one, you mean this one should. No. I think here this should touch here like this, right?
No, the tragus is the center point of the ear.
But I don't think normally tragus will touch to the level of eyes in normal.
You can. No, it's a landmark. Then how can you say?
No. Tragus means this one. Wait, tragus is this, right?
Yes.
No. Just this upper part should touch, at least 1/3 of the upper part. You do it for yourself, you will get to know. You draw a line from your lateral canthus. Tragus will not come. It will be like this. Wait, I will show you in a normal child.
Okay, no problem.
Okay,
But
just check this tragus means it will be 2 up a year. Means some part of the year you should be able to touch. Okay, no problem. Thank you all. Regarding the growth hormone in Noonan's, it is given in patient info. Okay, I just read the managements and only investigations from patient info. I wanted to read Mark and Khidr, but I could not. I just
Noonan is, see, Noonan, again, as you told that if the old enough adolescent age or pre-pubertal, we can give testosterone in male, and if the female estrogen can be given.
yeah.
And they are considering growth hormone also in these childs.
Yeah, and
They are
also
considering.
always they can ask this question like at what age you will start the same thing. 4 to 6 years is the good
Yeah,
age to start growth hormone.
yeah,
Then at
5 years.
10 years,
Yes,
then at 10 years you should also consider along with the growth hormone the oxandrolone. That is the
yes.
steroid, right?
Yeah, this is also- and input from the cardiologist, input from this. I don't know. This they are doing surgery for this drooping eyelids or not. Cosmetic surgeon. I don't know this one.
Okay, no problem.
And again, female gynae ops. If male infertility clinic, you will have to involve. These are the things, and
They will
definitely
also have the
education.
infertility like Turner's, same.
They have problem with that. Not infertility like that. I think they have problem with that.
Okay, no problem. We will check. Okay, then I will end the meeting. Huh?
Okay, okay, okay.